Bismillahirrahmanirrahim. Let's talk about acute pancreatitis. So, acute pancreatitis is actually a reversible injury of pancreatic parenchyma associated with the inflammation. The risk factors for acute pancreatitis include biliary tract diseases such as gallstones, alcohol consumption. The biliary tract disease and alcohol consumption almost constitute the 80% of causes of acute pancreatitis in the West. So there may be genetic factors that may be involved in acute pancreatitis. Infections such as mumps is known to cause acute pancreatitis. Certain drugs such as azathioprine, estrogens, and furosemide are known to cause the acute pancreatitis. And there is scorpion sting, hypercalcemia. So once the calcium concentration starts to rise inside the acinar cells, they tend to activate the trypsinogen into active form, which is trypsin. Many metabolic disorders such as hyperlipidemia are also associated with acute pancreatitis. So the enzymes that are produced by the pancreas are actually very powerful digestive enzymes. There are certain mechanisms through which the pancreatic parenchyma is prevented from the damage by these strong digestive enzymes. So that these enzymes are synthesized and packaged as inactive proteins. So what are these inactivated proteins called? They're called as zymogens. These zymogens are packaged inside the granules and then transported to the second part of duodenum. The next is that the most pancreatic enzymes are activated by trypsin itself. Once these enzymes are transported to the second part of the duodenum, trypsinogen is activated by the duodenal enteropeptidase. In turn, trypsin activates all the other enzymes of pancreas. The duodenal as well as the acinar cells of the pancreas secrete a specific protein which is known as SPINK1 or a trypsin inhibitor. SPINK1 actually inhibits the conversion of trypsinogen into active enzyme. Let's move on towards pathogenesis of acute pancreatitis. The first incident that occurs in the development of acute pancreatitis is that the trypsinogen activates itself to form trypsin. And how this activation occurs, there's a separate discussion, we will discuss it later. For now, we have to know that there is an inappropriate activation of trypsinogen to form trypsin. So what is happening is that trypsin in turn activates prophospholipase to form phospholipase, which damage the cells around and inside the pancreas. So once there is fat necrosis, it releases certain cytokines and inflammatory chemicals inside the blood, which give rise to inflammation and result in pancreatitis. The next there is proelastase, which is converted into elastase, and it damages the blood vessels. This elastase enzyme damages the elastin protein found inside the blood vessels. Next there is prokallikrein, which is converted into kallikrein, and it activates coagulation factor 12 and complementary pathway resulting in thrombosis. So all these factors including fat necrosis, damage to the blood vessels, and thrombosis result in the inflammation and acute pancreatitis. Let's talk about how trypsinogen is activated into trypsin. There can be many reasons to it. One of them is pancreatic duct obstruction. There could be primary cell acinar injury and defective intracellular transport of the proenzyme. So let's discuss them each. The bile stones and all these factors lead to the blockage of pancreatic duct, which results in the accumulation of pancreatic enzymes inside the parenchyma. So one thing you need to remember is that lipase is always in an active form. Lipase is always in an active form. So what it does is it starts to damage the fat cells inside as well as outside of the pancreas, resulting in fat necrosis. So once there is fat necrosis, it acts as a danger signal and releases certain cytokines and inflammatory chemicals which recruit the leukocytes to the site of inflammation. These cytokines as well as the inflammatory substances also increase the leakiness of blood vessels, resulting in edema. It also suppresses the blood flow to the pancreatic parenchyma, resulting in ischemia. So all these factors lead towards the acute pancreatitis. So let's talk about primary acinar cell injury. There are certain endogenous as well as exogenous insults which can damage the acinar cells, which results in the oxidative stress. So what is oxidative stress? Oxidative stress means excessive production of reactive oxygen species inside the cell. So reactive oxygen species include hydroxide ions, superoxide ions, and hydrogen peroxide. These are known as reactive oxygen species. So reactive oxygen species damage the mitochondria, resulting in mitochondrial injury, which leads to the influx of calcium inside the acinar cells. So once the calcium concentration rises inside the acinar cells, trypsinogen activates into trypsin. The other way is that the reactive oxygen species also enhance the production of transcription factors such as AP1 and nuclear factors. So these transcription factors upregulate the production of chemokines and inflammatory substances that result in the inflammation. The next is that there is defective transport of the proenzymes. Normally what happens is that the lysosomal enzymes as well as the digestive enzymes from the pancreas are produced and transported by the separate pathways. What happens in case of certain metabolic disorders and oxidative stress such as alcohol consumption, that the delivery of proenzymes occur to the lysosomes. The lysosomes contain the hydrolases which activate the proenzymes into active enzymes. So these active enzymes result in tissue damage. The patient of acute pancreatitis typically presents with the abdominal pain located in the epigastric area. The pain might be radiating towards the back or scapula. There might have been many episodes of vomiting and anorexia. The patient must also be examined for the features of jaundice such as yellowing of the sclera. Abdominal examination might sometimes find the bruising around the umbilical region, which is known as the Cullen sign. In case the bruising is present around the flanks, this is known as the Gray Turner sign. Serum amylase typically starts to rise within 24 hours of the insult. The normal value of serum amylase is 30 to 110 units per liter. Serum amylase is not very specific. You have to correlate the serum amylase levels with the clinical picture of the patient. Serum lipase, on the other hand, is very specific and it begins to rise in 72 hours. There might also be hypocalcemia. One thing you have to remember is that the diagnosis of acute pancreatitis is purely based on clinical presentation, then laboratory tests and radiological findings. Coming on towards the morphology, as you can see, this is the gross picture of the pancreas. You can see here are the hemorrhagic areas and areas of fat necrosis. In mild cases of acute pancreatitis, there might be inflammation, which is characterized by the presence of neutrophils and other inflammatory cells. There might be edema and fat necrosis areas. So all these components are present in the mild forms of acute pancreatitis. In severe form of acute pancreatitis, there might also be liquefactive necrosis of the acinar cells as well as the islets. There are also the hemorrhagic areas which are due to the damage of blood vessels due to elastin enzyme. The long-term complications of acute pancreatitis include pseudocyst formation and pancreatic abscess, whereas the short-term immediate complications of acute pancreatitis include disseminated intravascular coagulation and shock. Both of these complications can prove to be fatal if not taken care or if not dealt with the emergency, increase the mortality rate in acute pancreatitis. So the full-blown acute pancreatitis always constitutes an emergency. If you have any questions, do let us know in the comment section. Thank you.